to treat acne. How to figure it out. Because for some reason, it's hard for people to figure that shit out. So you see somebody and they're coming in for acne. First thing you need to determine, is it inflammatory or is it not inflammatory? How do you determine if it's inflammatory? It's red. Inflammation, red. What are the things that are red? Inflammation, infection, all that kind of stuff. It's red. So if you have zits on your face, blackheads, whiteheads, comedones, whatever you want to call them, they're special lesions, by the way. And there's red around it, usually a lot of red, it's inflammatory. So what are they going to need? They're going to need an antibiotico, as they say in Spanish. They're going to need an antibiotico. If it's mildly inflammatory, you can probably get away with a little topical antibiotic. If it's not mild or moderate, they're going to need an oral antibiotic. Everybody, la-di-da-di, everybody that has acne needs a retinoid, a topical retinoid. Usually starts at the lowest strength. You put a little pea-sized amount here, 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 after they wash their face at night. Every day, if they don't tolerate it, you do it every other day. So, if they have zits, if they have open to the air zits, they're blackheads, because the sebum has oxidized because it's exposed to air. If you use Retin-A, it will close up the pores and get rid of those zits. All you'll need is a face wash and Retin-A for non-inflammatory acne. That's really all you need. It takes a month or two and they'll kind of go away. If they're really big zits, there's a fancy thing you'll probably see in phase 2 called a comedone extractor. Kind of a prehistoric looking, but not medieval looking. Long needle-like thing where you can push around and do roof these things. You guys seen, what's that doctor on TV? Dr. Pimple Popper? He uses a comedone extractor every now and then. You get big zits out of the face because you'd be putting Retin-A all day on there, and if it's the size of a pencil eraser, it's not going to do anything. But that's really all you need to do. So if it's inflammatory, mild inflammatory, they're going to need an antibiotic, probably doesn't need a pill. You put the Retin-A on every night. You'd use a topical antibiotic twice a day and a face wash. Everybody needs an acne face wash. If they don't have low bad acne, like Dove soap, twice a day. If they have acne, inflammatory acne, benzoyl peroxide face wash. 5% benzoyl peroxide face wash. Okay. Whatever flavor you want to buy. More expensive doesn't make it any better. If they have, like some people you'll see, they won't want to show you because they'll be embarrassed. If they have these big bumps and zits on their chest and their back, especially the ladies, they need some topical benzoyl peroxide, 10%. Have them put it on at bed at night. Wear a white t-shirt, so because benzoyl peroxide will bleach shit. So have them not use it in the morning on their uniforms. If they have white spots on their uniform when they wash it, and first start to be in their grill because they're bleaching out their green t-shirts and stuff like that. White t-shirts when they use the benzoyl peroxide. So if they have moderate to big inflammatory acne, they need an oral antibiotic. Our favorite one is doxycycline, twice a day. It took them a long time to get acne. It's going to take a long time for acne to go away. So when they come in and see you, if you have the capability, take a picture. You only give them a month's worth of medication, not because you're a mean asshole. It's because if you give them 3 months of medication, they're not going to come back. And they might not be taking the medication as much as you want. So you give them a month's worth of medication to come back, and you show them the picture, because they'll say they haven't gotten any better. They might not have gotten a lot better. They might have gotten a little worse, to be quite honest. Because antibiotics also have an anti-inflammatory property to them. So it's going to take 3, 4, 5 months maybe to get rid of their acne. If they need Accutane, and that's why I'm going to go through these slides pretty quick. Accutane is a medication that dries everything up. That's the side effect as you treat the dryness for it. It treats really bad recalcitrant acne that the oral antibiotics have not worked on. If you are a derm PA or dermatologist, those are the folks who usually prescribe it. They won't give it to you unless you've been on an oral antibiotic for 6 months. So if you're seeing a soldier, a sailor, airman, marine that has acne, and even if they have really bad acne, if they're not going to be in that duty station for more than 6 months, they won't be able to get Accutane. If they haven't been on an oral antibiotic for 6 months, they're going to think you haven't tried hard enough. You need to be on that medication for a while. Everybody wants to go to Accutane. So that's a lot of crap to try to remember. But that's really, bottom line up front is how you treat acne. You need to just figure out if it's inflammatory, non-inflammatory, and then you kind of go from there. There's a few other conditions I'll talk about pretty quick. I'll get you out of here before noon, before 11. Yeah, that's my goal. All right, acne. Then we'll talk about those other conditions too. All right, how does acne happen? Usually it's a problem with the sebaceous gland, okay? If you squeeze on the sebaceous gland enough, stuff is going to come out whether you have acne or not. So it's not always a hormone problem, okay, but sometimes if somebody has too much androgens, it causes you to produce too much sebum, it can cause you to have acne. That's why we give birth control to ladies sometime to address that. But another thing that could cause it with the problem is you put stuff on your face and clogging up your pores can also cause acne. You see the patient populations down there? That's y'all's patients. Everybody that's in the military pretty much fits those age groups. Once you get past 44, you're getting ready to bust out of the door unless you listed later. So everybody's going to show up with this stuff. Etiology, too much secretion from the gland, sebaceous gland, the pilot sebaceous unit gets obstructed by probably some kind of makeup. So ladies, and maybe some guys might use makeup or hold too much sunscreen, use oil-free stuff. If it has oil in it, it's going to clog your pores and cause you to have acne. There's a bacterial colonization, especially if you clog it up. The bacteria is Rhopinium bacteria acne. It's the specific one that you need to worry about for test purposes, and Dr. Cyclone will take care of it. Minocycline, I think I told somebody this yesterday. Minocycline is an antibiotic that's more specific for this bacteria, but one of the side effects of minocycline is causing your skin to turn blue permanently. So I have never prescribed it that much once I found that out, because I don't want to turn anybody into a Smurf. So I don't give minocycline a lot. I know some people, that's all they prescribe for acne is minocycline. But I'm chicken, so I don't do it. I give them doxycycline. All right. Again, non-inflammatory, inflammatory. Non-inflammatory, you can have open or closed comedones. The open comedone is just that the sebum has been exposed to the air, you get blackheads. Closed comedones is the averse. So pictures determine, whether it's inflammatory versus non-inflammatory. If it's got red around it, especially a lot of red around it, it's inflammatory. We're going to need, if it's mild, a topical. If it's, they can use a little oral too, but maybe some topical. There's a medication that has benzoyl peroxide and a topical antibiotic called clindamycin, called benzocaine, that I'll specially give to soldiers, Army, male soldiers, because they'll use something twice a day if they won't take pills. So I'll give benzocaine to them. Ladies kind of like a topical clindamycin solution. So if they have like mild to moderate acne, give them a face wash, benzoyl peroxide wash, 5%. The Retin-A at night, everybody gets that. And then I'll give them some clindamycin solution because it mixes better with the makeup they put on their face. It's more of a solution, so you can put it on just like Retin-A and rub it in, and it evaporates, and then they can put on their oil-free makeup. Guys won't do that. Pretty straightforward clinical diagnosis. Everybody knows what acne looks like. Differential, there's some other things that down there on the list, but I'll tell you what those are in a minute. Patient-centered, you're going to ask them what they tried as far as treatment. Again, I told you there's no quick fix, it's gonna take months and months. They're gonna think they're gonna take 10 days worth of pills like bronchitis or whatever the hell you gave them their Z-Pack for, and it's just gonna go away. It's not. You're gonna just ask them how long you've had acne? Years. Well, it might take months. It might take months, maybe less than a year to take care of your acne. All right. Skincare modification again, so I've already told you guys about all this. Avoid occlusion with the makeup, sunscreen. All the fun stuff that we like to do causes zits, besides the makeup. Stress, coffee, sugars, all that stuff can cause you to get more zits. The 4 therapeutic targets. There's one medication that impacts all those 4 therapeutic targets. If you look on those lists. Retinoid. So any type of acne that you have, they need a retinoid or a medication like it. That doesn't mean an oral retinoid. We're talking about topical retinoids. Isotretinoin or the topical, I mean the oral is just for derm folks to prescribe. Don't worry about that. Then I'm going to go through the non-comedonal, inflammatory, non-inflammatory pretty quick. Again, non-comedonal acne, start with a retinoid. All these start with a retinoid. Low dose, 0.25 is kind of the low dose. It'll come in cream or gel, whatever your pharmacy has, start them on it. Cream, and like you learned, that steroids is more cosmetic or appealing. Gel, probably a little more inflammatory. If you use a retinoid, which everybody should use a retinoid, and some people have more sensitive skin than others, especially if they have inflammatory acne. And what does a retinoid do? It closes up your pores. It causes your skin to get really tight feeling, and then it's going to start peeling eventually. They're not going to like it, so they're either not going to use it. Then it's just like anything else. If you don't use it, it doesn't get any better. Tell them to take a break. There's nothing wrong about saying do it every other day, do it every third day. Just not do it, because they do need to use the medication. All right. Consider, if it's not working, increasing the strength of retinoid, just like a steroid. Here are some examples of open comedones and closed comedones, blackheads, whiteheads. All right. Mild inflammatory acne, then you're starting to get into where you're needing the topical antibiotic along with the retinoid. If you have a whole lot of pustules, maybe consider an oral antibiotic. Doxycycline is the one you'll probably see on the exam. I told you I didn't like minocycline. Your phase 2 guy might love minocycline. Don't tell them that you don't want to do it because you want to turn somebody into a smurf. I think you're being an asshole. That's just my gestalt with it. Doxycycline is kind of universal acne medication. Again, give them medication for a month, not because you're being a butthole, but because you want to see them follow back, see how they're doing. Only give them a month at a time for these medications. It's going to take more than a month. Moderate to severe topical retinoid. They all have topical retinoid. Topical benzoyl peroxide, oral antibiotic, doxycycline, twice a day for a month. So how many pills would that be? Because it's going to default. If you put in doxycycline in MHS Genesis, it's going to say 2 pills twice a day. It's going to give you 20 pills because you think you're going to give it for upper respiratory infection. Yeah, you're going to need it to change the prescription because you're going to need a month's worth of it. That's the kind of stuff you have to worry about. Consider if they have those nodules, acne nodules, you can shoot them with a steroid if you want. I've never done that much. I have a few times because remember, if you don't hit the steroid in the right place, you can cause that dimple that doesn't go away. So I don't do it that much. Moderate to severe, this is when we get into the Accutane, isotretinoin. It says derm only, doesn't mean dermatologist only. If you work for a dermatologist, they can go online and register and get a little number for the iPlench program. You can prescribe it too. It's all based on weight. The long and short of it is, there's certain labs that you have to draw each month before you give a new prescription, every month. It takes at least 6 months. So if they're not gonna be around for 6 months, you're not even gonna start it on them. If they're a female, they're gonna need 2 forms of birth control, and abstinence does not count as a form of birth control. So if they say, for example, it's against my religion and I've never had sex, and I don't want to take birth control, and da-da-da-da-da-da-da, they won't get Accutane. It's not because you're a bad person, it's because there's a government regulations that go along with this, and you're not the only one involved in it. It isn't like you're being in a butthole, because the pharmacist will ask them that question too before they give them the drugs, and they're going to want to see the results of those negative pregnancy tests. And they're going to see the result of them picking up, whether they're picking up their birth control pills or not. A condom is a form of the second thing. So it needs to be it needs to be 2 forms of birth control. Guys don't have to worry about that. Ladies, 2 forms of birth control. The biggest thing, like I said, the retinoids do is dry things up. So if it's topical, it's drying your skin up and it's sloughing. If you're taking it orally, it dries everything up. So you want to prescribe them things like eye drops, Eucerin or bacitracin for their lips. Their lips are going to peel. They're not going to want to do it. Everything, and it's going to dry up the inside too. You have to worry about it affecting your liver. So that's why you check your liver functions every month, because it can cause liver problems. If they start complaining of headaches, any kind of feeling weird, you need to stop it. It has a black box warning with Accutane causing suicidal ideations and really bad headaches. I've never had anybody that had any of that, but you need to counsel them on that. That's on these slides. All right, treatment, other options, alternatives, really bad acne. So, what type of acne is that?
Non-inflammatory.
Non-inflammatory acne. What kind is that? All right, so you can say, everybody has a different opinion. Opinions like assholes, everybody's got one, right? So it's a clinical diagnosis, and you'll get better at this as you go along. All I really want you to do is be able to determine inflammatory versus non-inflammatory. The mild, moderate, or severe basically is whether you give me topical or oral medications. That's what I want you to know in phase 1. But, I've had different opinions on these, and everybody has an opinion. What do you think that is? Moderate inflammatory? How about that? Yeah, she's not happy. Just tell she's not happy. All right. Severe nodular cystic acne, there's going to need Accutane too, but this is some of the ones you might consider doing injections for with the triamcinolone. Those are where it normally presents. People are not going to want to show you that on their back, especially ladies. So when you give someone Accutane, and they've been on all these other medications, doxycycline and all this other stuff, guess what? They've got to stop that. They've got to stop it. They'll just be taking the Accutane and using the stuff to treat the dry skin, the dry eyes. They'll stop all the other medications. And they'll have to stop the medications for about a month before they start the Accutane, because you don't want to turn your liver into a raisin. All right. These are really, really bad cases of acne. Nodular cystic acne, Accutane, same thing. Intralesional injections. Again, it dries everything up just like the retin-A does. And I've already told you that. Draw all these labs, birth control. Take it. And you've got to, even if they're taking the medication, you've got to do a UA on them every time. Before and after. And even after they're done, you got to do it again, because the medication is tetragenic. Tetragenic. When they're using Accutane, emollients, moisturizers for the skin, lubrication for the lips. Avoid alcohol, it affects your liver. Only a month at a time, they won't let you prescribe more than a month at a time anyway. And it's all based on the weight. I can't remember if I have it in the slides or not anymore, but it's 1 milligram per kilogram is the formula for dosing Accutane. 1 milligram per kilogram. Then headaches, acting cray-cray, or having suicidal thoughts, stop the medication. In fact, if they complain of any kind of mood swings, stop the medication. All right, don't worry about that. These are some really bad cases of acne. All right, we're down with just regional acne. Adult female acne, what do you think this is? Ladies' acne usually presents along the jawline. Very painful, it hurts. Okay, what do you think you're going to give them? If they're not on birth control, give them birth control. That'll help out with that. Because sometimes, the only time this presents is around their menstrual cycle. The only thing that's going to modify this, and say they're not having sex, all right? They don't want to take birth control all the time. But they get this acne around their menstrual cycle all the time. Well, you just have them take birth control for a week or so before they normally get their menstrual cycle, and this might not pop up. Then when they're on their menstrual cycle, they can quit taking the pills. That's how you don't have to take birth control all the time to prevent adult female acne. But it is one of the medications we give for adult female acne. But you can get to where, a lady kind of knows when it's getting ready to happen, and they can kind of prep the target and maybe it won't pop up so much. Very tender, can't put makeup on it, make it go away. Red hurts usually on the jawline. Oral contraceptives and spironolactone. It regulates the androgens along with the contraceptives, and that's what's causing it. All right. My favorite oral contraceptive for this is orthotricycline, just because I'm familiar with prescribing it. Spironolactone. And again, they might say I'm not sexually active, I don't want to take a birth control pill, and say, well, you like having the acne around here? And say, no, then just take the birth control pill a few weeks before your acne normally pops up, before your menstrual cycle, and that's the only time they have to take it. All right? Only time they have to take it. Then spironolactone blocks the androgens. Now, we'll blow through the rest of these and get you out of here before 11. Perioral dermatitis, it's a rash, dermatitis, inflammation of the dermis, usually perioral, around the mouth. That's how you're going to know this. And how you're going to know it's not some other kind of contact allergy around the mouth. It spares the vermilion border. It spares the area around your lips. So by looking at it on an exam, you see a mouth and a rash around the lips. It spares the vermilion border. It's perioral dermatitis. How do we treat it? Same way you treat any kind of dermatitis. This one you can give an oral antibiotic, doxycycline, and it tends to help with it. All right. Moisturizing creams can exacerbate it. I had a person that came every time they changed their toothpaste, they're all from getting the latest toothpaste that causes their teeth to get whiter and whiter and whiter. It gave them perioral dermatitis. So I had them change their toothpaste and it went away, but you can help it go away faster with a little oral medication. Doxycycline is what I like to use. A little hydrocortisone cream for the redness, a little tiny bit, not much. Perioral dermatitis spares the vermilion border. See the rash around there? What else could that be in your differential that I haven't told you about that much? Sebderm. Seborrheic dermatitis is not necessarily perioral, but it does pop up on the nasolabial folds. Here, usually they don't have scale, it can be kind of greasy, where perioral dermatitis isn't. Okay? Clinically, that's how you can kind of differentiate it. All right, acne rosacea. This looks like acne. They'll have, it's basically redness on your malar area, maybe your forehead, your nose, and your chin. It can have a nodular component to it like acne. Once it gets the bumps, the nodules, it'll need oral antibiotic. Oracea is like one of the ones that pops in my mind. Normally, it's treated by a topical medication called Metrogel. Topical flagyl on the face will treat acne, rosacea, but once it gets nodular, it needs an oral, like doxycycline or oracea. Theory is that a mite called Demodex follicularum can exacerbate this. Some people, they know they have it. I had a Sergeant Major one time, every time he got pissed off, his rosacea would pop out. That would even make him more pissed off because it was embarrassing to him. And he didn't want to go on sick call because he's Sergeant Major. He's too Sergeant Major to go on sick call, so I'd have to go see him in his office and give him the hookup for his rosacea because he didn't want the soldier to see him on sick call. So, you'll be able to notice it and see it. Everything that you guys do for fun makes it pop up. Spicy food, booze, coffee, stress, getting pissed off, makes rosacea flare up. I have a few pictures of it. Rhinophyma, that word that's bolded down there. You guys, you're too young to know who W.C. Fields was. You guys ever see a picture of W.C. Fields? Old, silent movie actor? You don't care. He was a big, giant nose. Big, giant, that's rhinophyma. And it's acne rosacea that affects the nose. In phase 2, the first time I saw this and got to treat it because the Accutane didn't work on it, guess what you get to do? You guys know what a bovie or a hypocator is? It's a pen that's powered with electricity, and you can cut or cauterize or stop bleeding with it. It has little tips, and you can also perform surgery with it. And what you do is, you see how you numb up somebody's nose. There's epinephrine going to tell you not to, because it stops the bleeding and everything. And you take that bovie and you carve their nose down. You carve that out, basically carve all that stuff off. And then put a bunch of acid tracer and Bactroban on it, and then come back and follow it up. You fix it. It's the grossest stuff you've ever seen. It stinks like hell. But if you're lucky in phase 2, you like that kind of stuff, you'll get to treat some rhinophyma. All right, fair skin folks, usually people of my skin persuasion. What causes it? Vasodilation, all those fun things down there exacerbate it. May burn or sting. Management, you try to avoid what's causing it to flare up, and you don't cure it, you just treat it. Acne rosacea is, you just treat it, you don't cure it. Metronidazole, flagyl, topical BID, that's what you do. Acetic acid, that's that thing you can treat pseudomonas, folliculitis with. That's another thing you can use it for. And then tetracycline or doxycycline. Really bad, isotretinoin or retin-A, not retin-A, but Accutane. If that doesn't work, then you can carve it up. That's a picture of a Demodex follicularum mite. I never seen one on that slide and everything. People don't believe it when you tell them it might be a mite. Here's newsflash for you, we all got them. Those things are on all your skin right now. Doesn't mean you have rosacea. If you have an overpopulation or over flare-up of them, it causes some people to get rosacea, but you guys all got cooties on your skin right now. Besides the staph that normally kind of hangs out on your skin, you've got little critters on there too. You've got these Demodex follicularum ones. There's a theory that you can take Vermox and drive the neck and get rid of it too. All right, these are pictures of rosacea. Has that slap cheek appearance. This not a viral example. It's not this disease. This is usually adults that have this, not children. This lady's starting to get a little rhinophyma. See how her nose is starting to spread out a bit. That right there is a good case of it. And if Accutane didn't fix that, the only way to fix it is a little bit of skin modification. Skin modification. Steel heals. Another one I like to use is charcoal doesn't bleed. So if you have a bogey with you and you cauterize something, you stop bleeding, you're able to treat the bleeding. Rhinophyma. Pomade acne or acne cosmetica is acne caused by you clogging the glands with cosmetics or whatever you put in your hair. If you pull your hair back and expose all these sebaceous glands and everything, and you put something on there, it causes acne. Be careful how you're counseling some people about this to treat it, because they're not going to want to stop doing what they're doing. So they either want it treated or they don't want it treated. Management, it's a lifestyle change. Benzoyl peroxide, like anything else, like I told you with acne, a little topical, you don't need an oral antibiotic for it. A little benzoyl peroxide will help. Maybe a little retin-A to close up the pores and cause it to slough off a little bit. But the big thing with acne cosmetica is stop doing what's causing it. Steroid acne, history tells you what's causing this. Stop the steroids, the acne goes away. If they've never had acne, this is one of the first or second presentations of it, and they've never had it before, and it's popping up in places where acne normally doesn't pop up. Where does acne normally pop up? On your sebaceous areas, hairy areas. If you've got acne like zits down the middle of your back, that's not normally where it pops up. And if the history is they just recently finished a big giant thing of steroids, once they quit the steroids, it goes away. Just treat it symptomatically. This is going to itch. Most zits don't itch. They might hurt, but they don't itch. So if you have zits popping up where they don't normally pop up and they're itchy, see if they've been taking some steroids. Give them something symptomatically. Give them some itchy medicine. Atarax, Claritin, something, a little benzoyl peroxide for it. Help them out. Often itches. It doesn't mean they're allergic to steroids. It might have just been, it's safe to be them that time. Quit the steroids. Treat it topically. Give them something for the itch. We're almost done. My gunny over here is about ready to fall off the seat. All right, Lillian. You used to be scared of guns. Not anymore. I'm not sorry, but I'm scared of gunny. If you ever talk to anybody more than a sergeant, oh God, dog it, man. If you're not familiar with the Marine Corps, gunnies, man, they were just like walking on the water. You didn't talk to gunnies. Just yes, sir. No, sir. Aye, aye, sir. Left foot, right foot. Get the hell out of Dodge. All right. Millie or small cyst. Small cyst. Small epidermal inclusion cyst. They're cysts. They're not zits. Retin-A and all that kind of stuff. Oral antibiotics not going to do diddly for it. Okay. If it's on little kids, you see a lot of times you'll see these in babies. The moms will bring them in and they'll be trying to pop that zit on their eyelid or their forehead. Tell them to stop. Don't be mean to them, but tell them to stop. A lot of times they'll resolve on their own. If you see these on ladies because their cosmetics won't cover them up anymore, these bumps won't go away, here's how you treat them. If they really, really want them treated. You can get that hypercator, that little bovie thing, light it up and touch it, and it pops like a popcorn. Goes away. It won't cause a scar. It's very superficial. Or you can get you an 18 gauge needle. You guys familiar with an 18 gauge needle? They're very sharp. You can malpractice people with them too, other than just stabbing them. You basically unmove it. Put that little 18 gauge needle up underneath that cyst and just pluck it out like a raisin. You're done. You fixed it. That's how you treat it. I try to talk them out of it and let somebody else deal with it, because I don't like putting needles around eyeballs. All right, tiny cyst, pea-shaped, most commonly around the eyes. It happens. It happens. Management, extract it. Multiple might use retin-A, but then, I've never seen a whole lot of help with that. Heat rash or nibly area, treat that with cool compresses. If it's red, you give them something for the itch. It's heat rash. Prickly heat. It's sweat retention of the eccrine gland, not apocrine gland, not sebaceous gland. Come on, Goody. Line that one right there. The eccrine gland, not the apocrine gland, not the sebaceous gland, it's your sweat gland. Okay, it's a heat rash from the sweat, from heat. You treat it with moist, cool compresses and humidified air. I'm sorry, I love Marines. All right. Now, I was a teacher here with the first Marine that came through this program. The very first one, he barely got through this. He was a truck driver. And my Lord, man, he got a lot of magic PA dust sprinkled on his exams because we weren't going to let the first Marine coming through here to smoke in. I'm not going to mention any names in case y'all might know him, but he's still on active duty because it was 10, 15 years ago the first Marine came through here. Big African-American guy, about this big, the nicest guy you would ever meet. His head was this big. But he was this big too. He was like a picture perfect Marine guy. All right. Not like skin games. All right. Okay. Heat rashes. Self-limiting, you treat it, it kind of goes away. Reassure mom it's going to go away. Give antihistamines that it's itching. Here's a good one. We're almost done. Hidradenitis suppurativa. This is a cool one if you like surgery. Anybody going to be a surgery PA in here? This is who you need to refer these things to. When you see this, it's going to be very obvious. They say you can treat these with Accutane. I never have been able to have one resolved with Accutane. You'll see what's called a double or triple comedone, open zit. Will kind of be in the sebaceous areas, usually in the armpits, on the butt, in the groin, where there's dead space. Guys, did you learn about dead space in surgery yet? So when you have infections in the dead space, infections will track through that dead space. That's why you send these to surgeons, because how do you think you're going to cure this? You're going to cut this stuff out. And the way you figure out how much to cut is you'll IND it and get a lot of that pus out. You'll put this stuff in there called gentian violet. Have you ever heard of gentian violet before? It's purple. It's violet. It's violaceous, as they say on one of the slides back there. You put it in there and it'll track where that stuff is. So it'll actually stain the tissue as you drain a lot of that pus out, because this has lakes of pus. If you see the term lakes of pus on any exam the rest of your life, is this. Hidradenitis suppurativa has lakes of pus up underneath the skin. And if you pigment that, you'll see how far it goes, but you need a surgeon to get back in there to get all that out. Dermatology guys, we like the epidermis, the dermis, and maybe the subcular. We don't like going down into the skin planes and down into the dead space. We don't like that. Too scary. Now let's jump in. Do my George Bush thing here for you. Send them to the surgeon. Send them to the surgeon. Almost every time, you guys have heard, you've had women's health already, right? Polycystic ovarian syndrome, have you heard of that before? I've seen a lot of ladies that had PCOS and had this too. Not sure why. I'm sure it has something to do with something. But I saw a lot of people that have this. Axilla groin where it normally pops up, suprapubic area underneath the breast, double, triple comedones is what you're going to see, other than the lakes of pus. It'll be very fluctuant. It'll be painful. By the time they come to see you, it's not a pilonidal cyst. Have they talked to you about pilonidal cyst? Yeah. It's not that. It's not very, because I treated those all the time as a PA. IND it, pack it in some iodoform gauze, and follow them up. This goes a lot deeper than a pilonidal cyst. All right. Double comedone. What you need for exam purposes, probably. Management tells you how to fix it, but I've never really seen it get fixed except for surgery. You IND it temporarily to get them at least comfortable. Pack what you IND and refer them, follow up and refer them to surgery. Probably put them on an antibiotic. Hot compresses, because that draws out the stuff that's building up in there. Here's a picture of the double, triple comedone. We'll be able to notice that. Very, very pathognomonic of hidradenitis suppurativa. Again, armpits, axilla, groin, bottom area. That's before treatment of that area. That's after. Looks like they took an ice cream scoop and scooped out the old armpit. They had to dig that much tissue out to get to the bottom of it, because it had trapped all the way in there. And the dead space in your perineal area goes back a lot further than that. So that's why you need a surgeon to take care of that. All right, these folks are not going to be happy, and then you can tell it's going to hurt. It's not going to be pleasant. All right. Staph folliculitis, treat the staph. Oral antibiotic, infection around the hair follicles. Fever, guys, this is all. You see a beard with folliculitis, it's staph folliculitis. Management, topical oral antibiotics. Bacter is the one I like to use, Bishop Purity. Cool warm compresses. PFB, we don't see this as much anymore. Used to see it all the time when we made people shave no matter what. Now you see everybody going around with this. You don't have to send them to the dermatologist to get permanent profiles, so they don't have to shave. So they will get PFB all the time. But PFB is caused by a foreign body reaction to the hair. There you go. It's not an infection. It's a foreign body reaction to the hair. So you get inflammation and irritation from the hair and not the bacteria. Can PFB become staph folliculitis? Hell yeah. How would you know? You culture that bad boy that tells you it needs an antibiotic. But 9 times out of 10, if you see PFB, it's a problem with the hair follicle. But we don't see it that much anymore because homeboys can grow beards now. You see them around here all the time. Razor bumps. Some ethnicities are more prone to them than others. I have seen a whole lot of white guys around here with beards. All right. How do you manage it? You modify the hair. Tells you about how to do all that. Basically, you gotta get the hair from not poking the skin quite as much. Topical steroids for the inflammation, and then in different ways of modifying how you shave. And then if you don't have to worry about shaving, you normally don't get this. When you normally start seeing this, when they go to boot camp, and they never had to shave, they make everybody shave because that's what you do, even if you've never done it. And then people start getting this, and they get it more and more and more. Some people will get this kind of stuff on the back of their neck, which I'm getting ready to show you a picture of. There's a different way of treating that. There's just a blown up PFB, the hair actually going back into the skin. That's what causes it. Acne, keloid nugae. See that big thing there? That's basically PFB gone crazy and turned into a keloid. And a lot of times it will start out with a little infection, and you'll put some topical antibiotics on it, it will melt, and they get bigger and bigger and bigger. So if you see small little bumps on the back of someone's neck because they're usually get high and tights or shaving their hair back there, then you can basically, because there's a problem with the hair, where's the hair follicle start at? In the dermis, right? So if you do a punch biopsy on the small bumps, that gets down past the dermis to the subcutaneous layer, you throw a stitch back there, and you've cured them. When you let it get this big, you treat it the same way, but there's no punch biopsy that takes care of that. You got to cut it out. So I got to cut one of these out in phase 2, just like this. And then you just numb the whole part of the neck. You get your 15 blade out, you excise all the way around it, and because of the way the scalp's attached to the skull, you can peel it off like a piece of carpet. You got a big hole back there. And you come in every other day, and you just put Bacter on it, clean the wound, you put a big dressing on it. But it's cool in that This is the one place, because if you do, your skin here is kind of mobile, some a little more mobile than others. It'll heal down by secondary intent. So you don't have to stitch up that big hole in the back of your head. It will heal down like this, and you won't even hardly even see the scar. And as long as they don't get high and tights anymore, they won't get this. And so if you're lucky and you like doing surgery and that kind of stuff, like we do, not going down past the epidermis or the subcutaneous level, maybe you'll get the excision of these. But that's the treatment for it, excision. A pill's not gonna fix that. A cream's not gonna fix that. Management, no more short haircuts. Again, if they're really small, topical antibiotic, maybe retin-A and everything, I've never really seen it work, but it needs to be surgerized. Laser beam, if you could have access to it. Excisional surgery is kind of what you do. There's some pictures of some smaller ones, so you can treat those. If you start seeing that, well, don't wait till it coalesces into a big giant nodule like I showed you a minute ago. If you have small little things like that, get your 1 centimeter punch biopsy out and take it on out and throw a stitch out there and do one at a time and you'll take care of it. They'll appreciate it. That's too big for that. When it starts getting confluent like that, it might be having pus, for lack of a better word, it's empyema, coming out of it because of the hair follicles there, but they're probably going to need an oral antibiotic. But still, in surgery, IND and surgery is the way you're going to take care of it. Cyst. These are large milia. Remember I showed you those little small cysts? Epidermal inclusion cysts, you'll be treating these every week if you want to. Or you can refer it to dermatology or surgery if you don't feel like doing it. The key to these is it's not a antibiotic won't help. Creams are not going to help. You've got to excise them. And if you don't remove the whole cyst, it has a little capsule underneath the skin, it will come back. The easiest way to do it, I used to want to try to show all my skills and try to dissect around the whole thing so I could remove the whole ball of crap out in one piece and say, hey, look how cool I am. It'll take you an hour to do it, maybe longer. If you don't have an hour, best thing you can do is get an 11 blade, poke that dude, stand back, have your medic squeeze it so you don't get any on you, and let it get all over the medic or whoever, and they'll think that's cool. And get it all out of there, irrigate it. I'll get a couple of cotton tip applicators, go around inside the hole, pull out the cyst capsule piece by piece, irrigate it till you don't see the cyst capsule anymore, and then throw some deep sutures and some superficial sutures, close up that dead space, and you're done. Sounds easy. If you're used to doing it, it takes a few minutes. If you're not used to doing it, you could be struggling with this, depending on how big they are, for a long time. So if you like doing skin surgery, they would love to have you do this for the dermatologist so they can do the cancer stuff. You can do this all day long at your dermatologist clinic. Epidermal inclusion cyst. How people normally get it is an infected hair follicle, and then your body thinks it's something going on bad, and it forms this little wall around it to protect itself, and you get a little cyst. How do you know it's a cyst and not something else? Up underneath the skin, like a lipoma, which I haven't told you about yet. You'll see a little like comedone-like thing on the top of it, probably, a little opening. If you squeeze it real hard, maybe something would come out of it. Don't do it, but that's how you would know it's a cyst. Most common people with oily sebaceous skin, Treatment, you don't have to treat it. They're benign. If it hurts or painful, then you probably won't treat it. If I saw something like that around someone's eye, could you go on with it that's a lot larger milia actually. Could you go in with an 18 gauge needle? Yeah, you could. I'd feel comfortable doing that. If you don't feel comfortable doing that, then send it to the dermatologist. There's a picture of a cyst. If you look real close, can you see that little brown dot right in the top of it? That's where the hair follicle probably got a flame a long time ago. cyst in someone's earlobe. If you're gonna remove that, do it from the posterior aspect when you're removing it, so that they don't have a scar in front. Ladies will appreciate that, if it's a lady. I've had to remove those before. Send that to the surgeon. They'll love you for it. That's too much, man, that's too much. So, how would you treat that? You'd have to go after each one of them. Take you a long time. That wasn't God, it was a glutton for punishment. That is an advertisement for boxers. All right, boxers, not tiny ones. Because irritated hair follicles turned into a bunch of cysts. Pilar cysts are look like epidermal inclusion cysts, but they're really, really hard and they're fixed and they're normally on the scalp. Usually in pairs. I had this lady, and I think this is the last one. I had this lady that came into me when I was a student in phase 2. She wanted her horns cut out. This lady's probably about 70. So I want you to cut my horns out. I'm like, what are you talking about? And she had a lot of hair. And she started doing like this with her hair. And she had 2 pilar cysts right here. Yeah, so I cut them out and moved them and everything. You know, she's happy. She's happy. They look like cysts, but they're not cysts as far as epidermal inclusion cysts. When you excise these, they won't be really moist inside or have all that keratinosis material. Will be kind of tough, kind of hard. Usually multiple lesions up. And that's it. We went through all that, and that was good on the word. So I think I've got 3 more. I think this is number 6. I got 3 more to chit chat with you guys about. So I see you guys Tuesday and Wednesday, right? Because Monday's a holiday. So we'll go over 2 Tuesday, and then 1 Wednesday, and then I'll give you a review after that one, and then your test will be Friday, and you can look under the pediatric test tomorrow. I'll be watching at home on Canvas as you're